In this episode, I sit down with Dr. Maggie O'Brian, who is one of North Carolina's few board-certified veterinary behaviorists, to explore what day-to-day looks like in a clinical behavior practice. From navigating complex medication cases to supporting overwhelmed caregivers, Maggie brings a wealth of insight into the evolving field of veterinary behavior. We dive into emerging treatments, the growing recognition of pain as a root cause in behavior cases, and the nuanced conversations that come with helping both pets and their people. If you've ever wondered what a comprehensive, medically informed approach to behavior looks like, this conversation offers an inside look into the heart of that work. And before we jump into today's episode, a quick heads up. If you're looking to learn more about helping dogs with aggression issues, head on over to aggressivedog.com because we've got something for everyone. For pet pros, there's the Aggression in Dogs Master Course, which is the most comprehensive course available on aggression anywhere in the world, and it's packed with expert insights and CEUs. For dog guardians, check out Real Life Solutions, a practical course for everyday challenges like leash reactivity, resource guarding, and dog-to-dog aggression. And if you want full access to expert webinars, live mentor sessions, and exclusive discounts, the Ultimate Access membership is just $29.95 a month. You'll also find info on the 2025 Aggression in Dogs Conference happening in Charlotte this September. That's all at aggressivedog.com. Check it out after the show. Hey everyone, welcome back to the Bitey End of the Dog. This week, we have a veterinary behaviorist with us, and you know how we love our veterinary behaviorists on this show. Dr. Maggie O'Brian is joining us, and we're going to be diving into a lot of different topics. When I was talking to Maggie before the show, I was like, I have a wish list of questions and topics I want to dive into. And she's like, yeah, sure, no problem. So I'm excited to have Maggie here. Welcome to the show.
Yes, thank you so much for having me.
So just to give the listeners a little bit about what you do on daily routine, I've given everybody your background in terms of your academic degrees and all the letters after your name, but tell us a little bit more about like a day in the life of your practice and what you're focusing on now.
Yes, so I am primarily in the clinical world, meaning I work with patients on a day-to-day basis. So we have a stand-alone practice in Charlotte, North Carolina, where we see dogs and cats for behavioral concerns. So it's myself, and I have a wonderful resident, and we have a wonderful team, including some trainers and support staff and things like that. So on a day-to-day, we just see dogs and cats for their behavior concerns. And then we also have a virtual branch. So we work with a lot of patients all over the country through video calls and things like that. So we're also able to help, again, dogs and cats with behavior concerns all over.
Amazing. And the difference here between you and some of my other veterinary behavior guests is that you are just straight on all clinically. You're working with patients. Yes. Because I know a lot of veterinary behaviorists are also doing research. They're teaching at universities, seeing some caseload, but your caseload must be massive because that's what you're focusing on strictly, correct?
Yes. So we see, it depends on kind of how many rechecks we see in a day versus new appointments, but typically we'll see anywhere from like 3 new appointments and then 3 rechecks a day, or sometimes the ratio is different from that. But it is just all patients all day, which is very fun. That's why I got into this. I just like working with people and helping individual animals.
Yeah, that's interesting because that was a question I was going to ask you. So what made you lean in that direction? So you were like, I just don't want to do any research. I want to stay out of the universities, and I just want to be in there with the patients. Or was there something else?
I think some people really thrive and love academia. I was never wildly drawn to the academic world, or academia world, I should say. Very obviously drawn to the academic world. But I just always got into this to help specific dogs and cats and their families. And so that's just what I find most rewarding. So that's what I've honed in on.
That's fantastic. And I'm going to pick your brain about so many different aspects of cases. But first, is there anything kind of new and exciting in the veterinary behavior world? We always get lots of really great insights, especially again from the academics, but also those in practice, and finding new insights with meds or different protocols. What's top of mind for you? Anything kind of new and exciting that might be coming across the trainers' desks at some point?
I think there's always a lot of things that people are thinking about or are coming up more and more commonly. Certainly they've been around forever, but things like being concerned about pain as a component in the cases we see, and kind of what pain options we have for dogs, how much does that play into their behavior or in cats' behavior. There's a lot more, I would say, inventiveness with how we can sedate certain dogs in a veterinary setting if they are very fractious, fearful in that setting. So that's been really fun more recently to work very hands-on with trainers and get plans together to get these dogs seen at a vet clinic that maybe haven't been seen in years. So that's been exciting recently. There's some cool research coming out about caregiver burden, specifically pertaining to behavior cases. So how stressful is it to have a dog with behavior concerns or have a cat with behavior concerns for the owner, for the people working with the owners? So there's always lots of new stuff and exciting things.
You're speaking my language because actually I've kind of seen the same phenomenon in the behavior consulting training side of things with regard to pain, as well as the caregiver side of things. But the many more people, including dog guardians, pet guardians, are becoming aware of pain. I don't know kind of where that really, like we started to see that shift. I think it's been a little bit of a concerted effort from lots of different organizations, from the veterinary side, the fear-free community, the trainer side, social media, and some trainers pushing things out there, canine arthritis management out in the UK. Like there's a lot of great resources helping educate the masses. And a lot of people reference like Dr. Danny Mills' study on, the pain and underlying medical issues, the high prevalence of it, right? So yeah, I'm very excited to see that. And on that note, we could talk about some of the pain meds, maybe especially as of late. So Librela being one of them as being controversial and something we could talk about. But let's dive into that side of things for a second. It's just pain meds, what you would typically recommend, pain trials. Like there's a lot of new stuff to kind of wrap our heads around.
Yeah, and it's such a prevalent problem that we'll see in our patient population, and whether they come in, the owners are very aware that their pet is painful, but more often there's not an awareness that the dog might be in pain or the cat might be in pain, and that contributes to a lot of behavior problems, just not as directly as the cat is limping, the dog is limping. It's more the dog is touch sensitive, or they're having out of character behavior at an age we wouldn't anticipate, or they're having aggressive behavior at a younger age than we would anticipate. So whenever dogs don't quite follow the rules, we want to be specifically concerned about pain. And obviously it should always be on our radar. But as far as treatment options and kind of what we do when we suspect that a dog might be painful, we always try to get them to consult with or kind of go back to primary care and consider working dogs up to the best of our ability for physical issues, or cats up. I keep leaving our cats out, but trying to work them up physically. A lot of times it's super helpful to, even if we're really suspicious of pain, or if they did initial things that indicate that the pet might be painful, we really try to onboard another specialist, such as a rehab veterinarian or, neuro or ortho, depending on what the problems are, but really trying to have a team approach. And then really nice now that there's so many treatment options for pain, just kind of an ever-expanding pool for us too.
Can you talk about the prevalence of any particular issues, pain issues? Are you seeing an increase in anything, arthritis or any other trends when it comes to that, especially in the US with the dogs? And maybe we can talk about breeds in that regard.
Yeah, so I don't know if there's an increase in prevalence, but there's certainly an increase in awareness, I would say, of dogs that are painful. So, NC State had a study where I think it was 20 to 25% of dogs under 4 have arthritis. So we're just learning to not focus on this dog is 10, we should think about arthritis. If a dog is 2, it should be at least on our radar of, is there possibly a medical component such as pain playing a role in this dog's behavior?
I wonder how much of that has to do with breeding and structural characteristics. Do you know if this study was looking at that by any chance?
That one was a mix of breeds. I don't think they pulled out any specific one. And that was, I believe, more like people that work at NC State or are associated with it and volunteer their animals for it. But there's certainly, certain breeds that we're going to be automatically, do you have this, you're a German Shepherd, do you have back pain? You're a golden retriever? Do you have hip issues? So we certainly have more breed predispositions towards certain issues that we want to be aware of. But we also don't want to, oh, you're not a golden, so your hips are fine. We don't want to be approaching things that way either.
Yeah. So talk to us about Librela now. That's made the rounds on social media lately, and people are concerned. And what is your insight there?
Yeah, so Librela is still fairly new. It came out in 2023, I believe. And so it is an anti-nerve growth factor. So nerve growth factor plays a role with arthritis and inflammation, and then obviously further down the line, pain awareness. So it's been in the UK for a little bit longer than in the US. It has shown to be very, very helpful for dogs. Certainly clinically, we have many cases that have a significant difference, I would say, in outcome based on being treated with Librela. There are side effects that are being reported. So increased drinking, increased urination is now, I believe, officially on the label for it. And then there's some kind of mounting concerns about neurologic issues. It's just very difficult to say at this point if it is a kind of a causative issue. Do they get really comfy and active and then they do something to their back that's, because they were so much more comfortable and they were more active than they had been in a really long time? Or is there kind of a more concerning connection there? And it's just so early that it's hard to say. And I think it's tough because the population that's being treated are primarily senior pets. Senior pets are going to have a higher likelihood of developing scarier things. So how much is that associated? So I think it's an exciting addition to our ability to help. Ironically, in the behavior world, it's an injection once a month. So we see these dogs where it's like, man, we'd love to try Librela in you, but realistically, without onboarding a team to help, how do we get monthly injections into this dog in a realistic way? So
yeah. How do you navigate conversations with your patients' caregivers in terms of, let's use Librela as an example, or maybe when the benzodiazepine, they read something and they're like, oh no, that's like terrible. And it's especially something like this where the data is getting there, but we don't have anything robust or anything that's definitive. There's concerns about it, right? And so maybe that caregiver is concerned. And they say, well, Dr. O'Brian, I don't know, I heard about this. And that particular med, whether it's for behavior, pain, or anything, is going to be probably the best option for that dog. How do you convince that type of concern?
So we try to never talk someone necessarily into a treatment that they are very hesitant to pursue, whether it's an anti-anxiety medication or if it's something that's strictly pain management. So if there's true, like, I'm really scared of this, I don't want to do it, then it's kind of a full stop. We'll explore other options. If it's more just that they have questions about it, then we'll kind of talk more about prevalence. With behavior meds, the incidence of side effects would be typically insanely low. So is your dog going to be this, one out of how many that has a weird side effect? Potentially, but it's just so low that typically the main focus is pros versus cons, and in the majority of the cases, the potential pros are going to vastly outweigh the potential cons, and that's true of any medication that any of us ever take. When they whisper the side effects at the end of the ads,
those are
really things
fast,
yes,
like 5 times speed.
Yes,
right. So speaking of the caregiver side, we have caregiver burden. And I imagine so many of your conversations are considering that side of the equation. So we're talking about, a person navigating, do I give my dog this med? And possibly they could be impacted by this particular side effect or this issue or this disinhibition or something I'm reading about or something somebody told me about. And then at the same time, if it's a profound aggression issue with a long-standing history, there's also obviously the ramifications for that. So talk us through some of the things you've learned over the years when it comes to difficult conversations like that with patients, and some tips and tricks that may be helpful for the rest of the listeners in general, but also the trainers and consultants listening in.
In terms of them being concerned about meds or just their stress level over behavior problems?
It's kind of a broad question. I didn't give you any specifics there, but I'm kind of looking for your insights and the human side of your consulting. What has been some of your biggest takeaways over the years? Like, wow, I used to have this problem with convincing a person to do this, or having that difficult conversation about potential outcomes, or how a med can be important. So it's a general sort of broad question about like any insights you might have that you've learned when it comes to talking to the humans.
Yes. So we do put our kind of therapy hat on fairly frequently. And some weeks feel like that's, a heavier part of our job than any other part of our job. But I would say that I try to outline our overall goals for patient care. So we want the dog to be happy enough with the plan we're laying out, or the cat to be happy enough with the plan we're laying out. We want the plan to be feasible for the owner. So I tell people, if this plan takes over 2 hours of every single one of your days, it's not an appropriate plan. So we need to figure out something that works for that individual. Mm-hmm. And then the biggest thing, because we deal with so much aggression, is that we need the owner to feel safe enough with the situation that we're living with. So they need to feel safe enough for themselves, for the pets around them, for the community around that pet. So I tell people on any of those three things, if we're not feeling like we're hitting, where we need to, then we do need to have a bigger discussion about, does it mean we change the plan? Does this bring up bigger questions for you about, are we going to be able to keep this pet in the home? If we can't keep the pet in the home, what are our options there? Because that's a whole nother conversation. So I try to just lay out those main goals and then emphasize, hey, if we're not hitting these things, you need to let me know so we can kind of regroup.
I love that you've kind of, in a way, you've learned like the system of navigating conversations, right? So you get to a certain stage in a conversation, you kind of know where it might go. And that's tough because you have limited time in a consult, right? You're not going to spend 8 hours getting to know every single detail about this person as well as their case. So you have to be really efficient in that time.
Yes. And luckily, we do have people fill out a lot of paperwork ahead of time. And then it does include questions like, have you considered rehoming? Have you considered euthanasia for this behavior problem? So having that helps navigate the conversation, because sometimes on paper, I'll think, well, this might be a behavior euthanasia discussion case. And they put, no, not even interested. So I know, hey, we're going into this with a plan of how to make things better. Sometimes you'll see cases where it's like, yeah, we're really at the end of the road here, and we know, okay, well, we need to talk about that on a bigger picture during the appointment. I think the trickiest appointments are the ones where we see a case that feels more potentially dangerous or more serious than the owner is really aware, particularly like in a young dog with, if you see a 9-month-old that's starting to growl at everybody, or if we're starting to see things where it's like, this is going to be a really challenging case. These are people that are going to have a young kid in the next couple of years. Those conversations are a little more challenging because you just know you're going to bum them out's not the right word, but it is. Yeah, you're going to kind of, give them news that they maybe aren't anticipating about how difficult things can be with some of those guys.
Yeah, that's got to be really difficult too, is it's inevitable, right? We're going to have some periods of our career, we're going to have a higher percentage of those kind of conversations. So what do you do in those times when it's like, oh gosh, it's one bad, I'm not going to say bad, I'm going to say difficult conversation, one right after the other, where you're having to help the client see the reality of their situation? What do you do to kind of help yourself with that?
I generally don't mind. I mean, I obviously don't enjoy making people feel, kind of bringing up issues that they may not have been aware of, but I enjoy the aspect of, being able to be empathetic and say, hey, I know this is not what you anticipated when you acquired this dog. This was going to be your brewery dog. You were going to go on group hikes, and we need to adjust what our goals are overall with this pet. So I think I enjoy helping people in that regard, even though they're tougher conversations. So I don't necessarily feel like I carry them home or things like that, because I do genuinely enjoy helping people with those conversations. That might just be my own weird, unique thing, but so yeah. No, it's definitely not for the faint of heart when you have to have that many. It can make for a tough week or a tough month sometimes, right? Yeah, and luckily the really heavy ones are not wildly common. And I try to tell people, like, we're not doomsday prepping here. We just want to be aware, as your dog gets older, if you notice new things, if you see escalation, we need to be aware of that. And this is what we're here to do to help. And so I think always ending with, these are all the things we're going to do to try to improve the situation and get things in a better spot. So I try to always have a level of optimism, as much as it allows.
Yeah. So just to back up a second, so you have this sounds like a nice intake form or way of getting some information. Does that contain elements of like a caregiver burden score? I think it's a ZBI or that particular tool. I'm seeing that used more in the veterinary field. Is that something that you find is could be helpful, or is this something you use?
So we do not, and there's been conversations about whether we should include things like that. Obviously, we are not human mental health professionals, so I never want to dip my toe in an area where it doesn't belong. And so I think just personally, part of my potential concern there is, okay, well, if they come back with this form that says they're really struggling, I'm not the right person to talk to you about if you have serious mental health concerns. So I think that's been a little bit on the mind is, are we opening the door for people to feel like we're the appropriate person to reach out for care?
Interesting point. Yeah. It's almost like you need to add another disclaimer there with a little checkbox,
Yeah, like if you're struggling. And the nice thing is social work and veterinary care has definitely expanded, and just resources for people that are living with pets with behavior problems have wildly expanded. So we have resources now where we can say, hey, this is really hard. The situation you're in is really hard. Yes. Here are all these excellent resources that can provide help. And we're here to help too, but there's people that's their main space is to support the human side of things.
Yes, I'm really happy to see that aspect of it coming into the field for not only veterinary social workers, but also for professionals to help pet parents know kind of how to navigate the after or even the during of a difficult situation. So I'm really happy to see that. I know Valerie Bogie as well as Marlene LaBerge are a couple that I've brought in for various aspects of the aggression space to talk about their expertise in that. And it's good to see that because it's so badly needed, right?
Yes.
For both sides, for both the patients as well as us as professionals. So yeah. Okay, I know this is what happens to me. I have so many questions that come up as we're talking that I tend to jump around a little bit. But I want to jump back a little bit on the meds topic and get your opinion on, since we're talking about questions from caregivers and, which med should I use and what is all this information swirling around on social media. But let's talk about over-the-counter or things that people can get without a prescription. So CBDs or pheromones, those kind of products. What are your thoughts and opinions on those type of recommendations?
Yeah, so there's a fairly big nutraceutical world in veterinary behavior, just behavior in general. So nutraceuticals would be your pheromones, your supplements like Zilkene, and all of those options that are available over the counter for people. CBD is certainly one of those options that people will reach for. The jury is still a little bit out in terms of the dosing for CBD and can you find a safe dose to help with behavior? There's more information available with CBD in the pain world and the seizure world. So clinically, I would say when we have patients that are taking CBD, it's typically because their rehab veterinarian recommended it for pain, is the primary reason we ever have pets on it. I do think I have a slightly unfair view of the nutraceutical world because usually by the time that we see cases, it's like, I've tried that, we've done that. So they've usually failed a lot of those things that are likely very, could be very useful in a certain population. It just don't find it as applicable to the majority of the population that we see. We certainly reach for them, not infrequently, but more often we're discussing prescription medications.
I'm going to answer or respond to this one carefully. So I get the same question a lot as a trainer or consultant. And of course, the right answer is ask your veterinarian or a vet behaviorist. But in terms of anecdotal experience, similar, they've tried, but by the time they come to me, they've tried all these over-the-counter things and these different products or gadgets or whatever. And of course, they haven't worked, or else they wouldn't be coming to see either one of us. So, you tend to get a different opinion of those products when you're in a particular seat. So totally understandable.
Yes.
Well, in that regard, do you see any of those particularly being effective for aggression cases or having sort of a higher percentage of efficacy with aggression cases? Anything exciting you?
For the nutraceutical world or just
just nutraceuticals. We can get into the other meds, definitely, but
I would say none of the nutraceuticals wildly excite me for aggression at this point. And maybe that, again, is an unfair opinion of them. When you talk about non-prescription, non-behavior prescription, the most exciting outcomes could be management of pain and how much that improves their behavior. So how much of this problem is not a baseline anxiety problem, how much this is pain. And so I get very excited about that aspect because it's really rewarding and almost sad in hindsight to be like, oh my gosh, this whole thing was pain.
Yeah. And some odd cases too.
Yes.
Sometimes you get like that placebo effect where they plug something in, or it's like a spray type of product, the olfactory factor involved, and the client actually, for whatever reason, they think it's working, so they tend to calm themselves. So with the dog, the precursor cues that a person would give with their own anxiety or their concerns or tension start to dissipate, which then the dog's like, well, okay, things are good now. So it looks like it's working sometimes when it's actually not, which is totally fine though.
Yes.
Right?
Yeah. Placebo effect is very, very real. Obviously in humans, then absolutely in humans' perception of their pets, because that's a whole nother layer of kind of making judgment calls. Mm-hmm. But all those kind of fall under, for me, they're not going to hurt. They may help. Mm-hmm. And so there's certainly things that are absolutely worth trying, and you'll get people that feel like they're game changers, and that's a wonderful thing. So
absolutely. Now there are a few that you always want, well, with any of them, we want to inform our veterinarian, our vet behaviorists what they're taking, but there are some that can interact with other meds, correct?
Yes. So CBD in particular can interact with some of the anti-anxiety medications. So it has some overlap, for instance, with how it's metabolized, with how fluoxetine is metabolized. Fluoxetine is a very common medication in the behavior realm. And then CBD tends to be a very common one that people will do over the counter. So it is very, very important to let your vet know what your dog is taking so they can kind of screen for, do we have anything here where we may not want to have both those things going at the same time?
What's a potential side effect or outcome if it's...
So theoretically, you can increase the levels of one because of the way that it's metabolized through the liver. So it can change the level of the drug. Clinically, we don't know how much that actually is a risk for that pet, but we just know that they use similar pathways to kind of get through.
Is serotonin syndrome a risk with over-the-counter or nutraceuticals in combination with one of those, or is that more when we're looking at prescribed meds?
In theory, it could be because some of the supplements are precursors for serotonin. Clinically, I would say we have very small levels of concern with combining those things, but it is always good to be fully aware of, because if we're getting creative with medications and we're starting to play with multiple things that increase serotonin, that might make us, well, let's just to be overly cautious, let's get that supplement off the table if we're getting more creative on our end as well. So we definitely like to know everything that people are giving their pet.
Yes. So on the topic of meds, since we're there, let's talk about prescribed meds and what Maggie likes to use or what's common, and it's a question I ask every veterinary behaviorist that comes on the show because I'm always curious what's the latest, but the standard answer, there is no latest. Like, we have what we're using and there's been tweaks, but one of the things that the trainers will say, well, like, what about trazodone and gabapentin? It's like they're being used so often in the cases they see, usually in the combination with fluoxetine or one of the TCAs. But so give us your overall pitch on meds first, and then we can get into the individual ones maybe a little bit more.
Yeah, so elevator pitch on meds is broadly for behavior. There's two big categories. You've got your fast-acting, as-needed medications. So classically, those get used prior to stressful events. So we tell people, just like some people don't like to public speak, or some people, are very terrified of getting on an airplane, there's medications that you can give dogs in anticipation of something that is going to stress them out. Those drugs tend to have big, wide dose ranges. The lower the dose, usually the less side effects, but also the less efficacy potentially. And then the higher the dose, the potential more side effects, but also potentially they're more helpful. So if you have a once in a blue moon stressor and the dog is totally zonked out on those as-needed meds. If it's rare and it gets us through it, then we'll deal with the sedation side of things. Those medications would include things like trazodone and gabapentin and clonidine and kind of all the benzos, all of those categories. They can be used daily, kind of in contrast to using them just as needed. The only issue potentially with using them daily for anxiety alone is that you get this dog or cat that feels better, then they feel worse, and then they feel better, and then they feel worse. So you get a lot of seesawing, and then you also get like this ride or die, if they're really helpful, on when the doses are due. So people will be like, oh my gosh, it's 6 o'clock. Can I please give clonidine? Like they're just desperate for the next dose of it. So the other categories, you're long-lasting daily. So those are typically pulled from antidepressants in people, and you are trying to get the baseline level of anxiety, reactivity, poor impulse control, whatever it is you're trying to target, to a lower baseline every day, but not change their personality and their goofiness and their joy, because those are all things we want, obviously.
Absolutely. So let's do this. Let's take a quick break to hear word from our sponsors, and then I want to dive much deeper into the meds side of things. So we'll be right back. Thanks for tuning in. I've got something really special just for podcast listeners. To celebrate the 6th annual Aggression in Dogs conference, I'm offering a limited time bundle deal that includes the Aggression in Dogs Master Course, plus over 30 expert-led webinars on topics like how to break up a dog fight, dog-to-child directed aggression, fear-based aggression, dog-to-cat issues, genetics and behavior, resource guarding, dog-to-dog aggression, and so much more. You'll learn from some of the most respected experts in our field, including Suzanne Clothier, Dr. Christina Spalding, Grisha Stewart, Laura Monaco Torelli, Trish McMillan, and Dr. Tim Lewis, just to name a few. You'll also get access to live group mentor sessions with me and join a Facebook community of over 2,000 professionals, all working with aggression cases. The total value of this bundle is over $3,000, but you get everything: the full master course, 30 plus webinars, live mentorship, and community access for just $595. Only 50 bundles are available, and this offer expires on October 31st, 2025, or when they sell out, whichever comes first. Just head to the show notes and click on the link for the Aggression in Dogs Master Course and Webinar Bundle to grab your spot. All right, we've been talking with Dr. Maggie O'Brian, and we've been talking about a lot of different things, but I'm going to do the deep dive into meds now and talk about types of aggression cases and which meds would potentially be the most appropriate. Now, of course, each case is unique, each case is individual, but so I'm asking you to kind of speak generally, which I know is not the easiest thing when it comes to meds, but with your classic fear-based aggression, you have dogs that are just fearful of particular stimuli. They go out in the world and they're having a tough time. So you could do the situational meds where it's just like, you're going to hike today and we got to get you out, but we also want to take the edge off. So that might be a situational med. And then you're looking at the antidepressant class. Those are the SSRIs, maybe, or a TCA class drug in which to help treat the fear. So we're talking more not just a dog that's afraid of garbage cans once in a while. We're thinking of dogs that just have a tough time outside, not completely learned helplessness, but just, picture that kind of dog. What are you looking at there for meds typically?
There's a lot of individual variation. So I tell people we do have certain meds that we might reach for with certain presentations. Unfortunately, dogs do not read our books and go to our presentations and say, yes, I have that problem and I will do excellent on that drug. So there can always be an element of trial and error, but there are certain characteristics that might point us towards certain meds. And this can vary too amongst veterinary behaviorists in terms of what your first choices are for things. Typically, if we are seeing an aggressive case where the pet may have poor impulse control, like the owners can't see the problem coming until it's happening. So it's like, I didn't even know they were upset and they bit somebody, where we really want impulse control. Fluoxetine still tends to be my first choice for that when you're strictly trying to treat an impulsive or aggressive dog or cat, potentially. There are other things, like if a pet has we call them like Eeyore dogs. So if they're just like, I just don't know if today's going to be any good, right? And the lamp moved 4 inches to the right, so the living room's probably off for the day. And, just if they're more fearful and withdrawn, I typically lean towards something like sertraline or Zoloft, which has slightly more effect on dopamine. And dopamine can be involved with motivation and reward. So sometimes that'll bring them out of their shell more. If we have a dog that has complete ants in their pants, like I'm in the room for 90 minutes and I'm just exhausted having watched this dog be active. Like they're on the table and then they're over there and what's in the window and I heard a small sound over there. If they're very, very busy-bodied, that might make us lean towards clomicalm or clomipramine, which is a tricyclic antidepressant. There's more impact on norepinephrine, which plays a role in that hyperarousal vigilance, on the go, on the go, on the go. So there are certain things that I joke with the assistant. I can say, like, I heard the dog asking for clomicalm through the hall because you can just hear their tippy taps for 90 minutes straight. So there's certain things that might lean us towards one or the other. But I tell people, like, your dog might look perfect on paper for something like Zoloft, and then we're going to find out 2 months from now that venlafaxine was the ticket all along. So we have guidance, and it can certainly help, but we're always ready to shift gears if clinically we're not getting the outcome we want.
So it sounds like when deciding on the appropriate med, which you feel is the best for the case, you're looking more like a personality profile versus a contextual type of aggression or behavior issue.
Yes, I would agree with that. So it's more just what's your overall, like, are you more timid? Are you more fearful? Are you 0 to 60? Are you constantly on the go, as opposed to conflict aggression gets this problem, or, so it's more based on personality than specific diagnosis, I would say.
What about the dogs that are, if I was to describe the personality profile here, just a dog that is not showing signs of fear, what they might have labeled like conflict control aggression years ago, or even dominance aggression years and years before that. But, the dog that is proactively sometimes using teeth to gain access to resources or to control the people in their environment. So we're not seeing the fear signatures. We're seeing hard stares, agonistic puckers, high flagging tail, straight spine alignment. So just, I'm going to come over here and make you get off the couch to the other dog or to the person. And so they're not responding to necessarily thwarting off a threat. They might be competing for resources, but they might be saying, okay, I'm going to proactively say, you need to go there, you need to go there, which is not a common case, but would you be looking at meds for that kind of case?
Yes. And typically, and again, it would depend on the whole pet, but I would typically, on what you just described, fluoxetine would still be top of mind for that. Interesting.
And do you see a lot of those kind of cases, or is that much far few between?
We don't as much. Cats tend to present slightly more in that way when you're talking about relationships between cats in the house. You'll get more of that. Yeah. Offensive kind of Lion King, everything that the light touches is mine kind of, I'm going to sit at the top of the stairwell and monitor everything. When we see dogs for resource issues within the house with another dog, it's more often that they are more insecure and the couch is over there and the dog's near my mom. And, they do present in a more anxious, concerned manner than a cool, calm, collected, everything around this is mine.
Yeah. Kind of speaking of that personality, let's talk about maladaptive behaviors. Let's just use a border collie, since we're talking about a dog that wants everything to be in its place. Yes. What do you typically go to if you have a dog that's presenting maladaptive, herding, or chasing the people trying to keep the people in the home? They're just trying to leave or get up to go to the bathroom. They're biting at their calves because it's a lack of enrichment. So we determine, okay, this dog's just not getting its needs met. Do you kind of look at, let's try to meet the needs first? Or do you say this dog has gotten to the stage of, well, we should probably separate this out a little bit. We can get into compulsive stuff where the dog's starting to chase shadows and lights, or we're just seeing it manifest in a different way. The dog's just hurting people in the home, but it's hurting people. It's like putting teeth on skin now, and it's getting very common, happens on a daily basis. What would you think of the med profile there?
Generally, we would still, I don't necessarily approach things wildly stepwise. So I tell people, if it's, yes, this dog is under-enriched, they have GI issues, they likely do have some level of anxiety or impulse control, or meds could help. I like to be in a position where 6 weeks after we've met with them, we're like, we're doing better. I don't know exactly which one of these is helping, but we're doing better. I am so much more excited to be in that position than super stepwise. And then it's, 8 weeks later, and we're like, well, we kind of talked about the GI stuff. Let's start treatment for that or start looking into that. And two, I think the potential problem with being very stepwise is that a lot of these guys they need more enrichment, they need training or behavior modification, they need meds. So if you do it super stepwise, it could look like, well, the training's failing. Well, the training would have gone great if they were on medication and could focus for a second. So I don't know that I actually answered your question, but...
No, it totally does, because it makes me think about the juggling of all of these potential balls of what could work.
Yeah.
So why hold off one, especially... And we could talk about the dynamic of how some people feel it takes forever to get a veterinary behavior appointment and all those dynamics, like in the interest of time. So that's one additional layer of these cases is the client time, their commitment level, their patience level, and something we have to consider. And we say, okay, yeah, we could just do no meds for 8 weeks, but then what? Now we've just spent 8 weeks. Now we have another 6 weeks for the med to take hold. So you bring up a lot of really salient points for this conversation. It's not just that. Let's just try one thing at a time. So it's incremental, right?
Yeah. And like you said, the client compliance and just how, we have this beautiful plan in mind. Well, it doesn't mean anything if the client can't realistically implement it. So that is definitely a really big factor we have to consider and try to encourage honesty from the owner of, is this... You got to let me know if this isn't doable to implement, like this enrichment schedule or training schedule. And yeah.
Yeah. And it's a perfect segue into the next sort of thought or question I have for you is I was talking to Dr. Nick Dodman and Vivian Zatola on another episode the other day, and we'd gotten into the topic of partial seizures and dogs that are the classic, I'm just sitting there, I'm going to attack you, or the blanket next to me, or I'm going to staring off, my pupils get dilated and I just start biting whatever's nearby. So not full-blown seizures, but partial seizures that one of the things that can happen is aggression. So high levels of aggression sometimes. So in that regard, of course, you might be working with a veterinary neurologist, and those are the cases where we're saying, okay, we've got a lot of balls we're juggling here, right? So can you talk us through a little bit in another day in the life of Dr. O'Brian working with other professionals? So let's say you see a patient like that, and you're going to be like, okay, we need to refer to this person. And so how does that done? And is that easy for you, or is it hard to get the clients to commit to that?
So it runs the gambit. There's definitely a lot of cases that we see that are not purely behavioral, where we do feel like there's something else, again, pain being the most likely case there, but pain, neurologic issues, gastrointestinal issues, allergies, where it just feels like, okay, this medical issue is not being fully met. We either need to talk with primary care about addressing this, or if it feels like it needs a specialist, then kind of onboarding the specialist that would be indicated in that case. Because if dogs don't feel good, it absolutely affects the way they perceive the world. It affects their behavior. So it can be really challenging to make improvements in a dog that does not physically feel well. So it's emphasizing the importance of that. And I think trying to appeal to the owner's empathy side of we just want your dog or cat to feel better. And it can be really challenging because a lot of this is expensive if they don't have pet insurance. They came to see us and I'm telling them they got to see another specialist too. And so it is difficult. And luckily primary care veterinarians are phenomenal and wear 10,000 different hats. So if they can't see a specialist, we'll talk to your primary care about what they can do to help. And so it's just kind of onboarding to the level that the owner is able. And then obviously trainers and things are hugely important and part of what we always try to onboard and involve as part of the team. And that's just another conversation about emphasizing how important that is and trying to relay that.
Yeah. And that's just like the human medical field, how often there's a lot of questions and confusion, who to talk to, what's going to get covered. So in regards to your practice now, I've chatted with a lot of different veterinary behaviors, and the system or the flow of how a patient moves through that process can be different depending on whether it's through university or through private practice or through just somebody in a satellite office. So for you, the patient, we've already learned, fills out this lovely intake form. You get to learn about them and learn about their wishes. And it sounds like we were chatting before the show, you only have about a 2-week wait lists, which is fantastic in the veterinary behavior world. And it's a misconception I like to clear up on the show too, because sometimes the general theme is like, oh, it's going to take 6 months on average for any veterinary behaviors. And that's not true. Some, yes, but there's plenty of availability depending on which practice you reach out to, and yours being one of them. So they fill out this form, they wait the 2 weeks, they get in to see you, you meet with them. So what is the next step in the process? Maybe we can use that partial seizure disorder dog as an example. Like you see the dog, you hear the history. What's next for them?
So in that case, it would obviously be trying to get them to go see a neurologist. Those cases, at least in my experience, those are pretty rare presentations. And we'll get more often people saying, like, I think this dog is having seizures or, REM sleep disorders and things. And then because there's no identifiable trigger. And then you ask, okay, when do you see ground? It's like, it's when I pet him when he's sleeping or when I pull him off the furniture. And you're like, well, those are identifiable triggers. So, but if that case were to present, it would be, yes, trying to onboard neurology, potentially if, like, let's say they're not willing to see neurology, do you speak with their primary care? Or do we start doing anticonvulsant trials and things like that? We always encourage a lot of follow-up. So I try to get people to email me at least once a week with how things are going for our follow-up window until we see them for a recheck appointment. I tell people, like, it'd be great if we could meet for 1 hour, your dog or cat goes home and you never have another problem a day in your life. That is just not how behavior cases go typically. So we're going to need to zigzag somewhere along the way. So I try to make that clear from the jump that part of this plan we're going to need to adjust based on your dog's response or your cat's response. So we try to encourage a lot of follow-up, and then we'll also try to get the ball rolling if we do feel like other people are indicated to kind of hop along the team. So if I think neurology is indicated, then we'll submit a referral for them. That means that neurology department's going to reach out to that client. So trying to provide, as few roadblocks as possible and get them the help they need without putting all of the work on the owner can be, I think, helpful as well.
And the outside professionals that you refer to, do you have like a local practice or a veterinary hospital nearby or attached to?
So I'm not attached. We're a standalone behavior building, but we definitely have a relationship with, the ortho people in the area and the internists and the ophtho people. So it's a small enough community where you kind of know, and we've got the neurologists that will let us send them videos of gaits and the rehab people who will give me opinions on whether things should be referred and to what department. And so having that community is really very helpful. With the virtual world, it's a little more of kind of just researching, okay, this is their zip code. Let's see who's in the area that would be best for them, or talking to their primary care about, hey, who's your go-to ortho person? Because I'd like this patient to go see that person. So
yes. And something earlier you said too really just shows the insight you have onto the human side of consulting, which is making sure you tell the patients, we're going to be doing some zigzagging possibly here, and just so you're prepared for that. I find that that's what experienced consultants learn to say, like they start to answer questions before they're asked,
yes.
right?
Yes.
So they sense what the questions might be coming, and they kind of help the clients understand. I think it's so important, especially in aggression cases, that the clients are made aware that, hey, we're going to try our best, but we're probably going to have to change course maybe a few times, because it's rare for those cases to go perfectly and everything we try the first time is going to go well. So in that regard, for trainers and consultants that might have the same conversations, you have a couple trainers on staff that you have to help with the cases. Do you also have a network of trainers you refer to in the area?
Yes. So we have all the people that we really like. And I do tell people, like, we have a list, and I say, I'm sure there's excellent trainers who, for whatever reason, I'm just not aware of and aren't on the list. If they're not on this list and you're really interested in working with them, please let me know who they are so we can do a little bit of vetting.
Yeah.
But if people come in already working with a professional that we like and uses the methodology is the primary thing we're obviously concerned about, then that's really helpful, because it's, they come in with a BMOD plan, they come in with environmental adjustments, and so it makes our lives significantly easier because they have that really good background. So then it's, we talk to the pet parent and then send all the info typically to them, and then the trainer, behavior consultant, just gets CC'd on all of our communication. So it's usually like a, hey, Team Fluffy email that goes on between everybody so everyone can kind of be on the same page. And then regionally, we definitely have since our trainers don't obviously travel hours to get to people, we see a ton of people from the Triangle area. So I have trainers I really, really love in the Triangle area in North Carolina. So it's nice to get to know specific people and be able to vouch and be like, oh, no, this person's incredible. Go work with them. And
What's the furthest somebody's come to see you?
4 hours, I believe, is the furthest. Yeah, we had someone from Georgia come at some point. Yeah.
Okay. Maybe we'll get somebody to fly in now that they're listening to the podcast.
Now when people call and they're like, oh, it's 4 hours, we say we have a virtual option. And people are like, yes, I will do that instead. So
is that in-state only, or can you do anywhere in the U.S. for the virtual option?
that is national. So
Wonderful.
Yeah.
That was that also changed during the pandemic? I know that was a kind of a weird thing for veterinarians before that.
So more research came out about virtual behavior consulting, I believe, secondary to the pandemic. I was in residency for the pandemic, so we didn't open until, obviously there's ongoing things, but we didn't open until kind of the worst of it was through and we could do in-person appointments. Our side of the virtual stuff really just came from being aware that there's large portions of the U.S. that do not have a veterinary behaviorist. And so just trying to increase access to care for those people.
Yeah. When I heard about virtual consults with VBs, I was like, the best thing ever just happened. So needed.
Yes.
And I'm so happy that that happened. It's such a great resource for people that don't have that access in their area. So just to back up a little bit on the trainer consultant role. So you have your trainers and staff, you have trainers that you work with. So the role of the trainer and the vet behaviorist, do you typically write the plans and then the trainer helps to implement them? Or is it sort of you see what the trainer consultant's doing and you say, this is good, or do you give advice, or what's the strategy there?
If they don't come in with somebody, then we'll kind of lay out, these are the main goals. And I would say as a veterinary behaviorist, I'm typically going to lean more on like, these are the environmental changes, this is management. So I don't get into details necessarily of like, these are the nuts and bolts of how you teach a dog to go to a place if they're on the couch and they don't want to move. I do throw a Cheerio on the ground to get your dog to move. And that's kind of, those are more the management tools because we're really trying to like put out the fire in certain situations and just quickly get to a better relationship. But then I say, hey, there's a lot of great ways we can navigate. Yes, your dog can get an excellent recall. Your dog can run to a spot on cue. We can teach pattern games and all this stuff that we can do with your pet, but it is going to go much better if you are under the guidance of a wonderful trainer that's in person and helping you in real time. And so then it is sending them like, hey, these are our main goals, but because they see a unique side, right? They go to the house, they absolutely zigzag based on what they're seeing. And so it's not like you must follow this guidance.
Yeah. I think those roles are confusing sometimes for some guardians. They're not sure, oh, wait, is it the vet behaviorist going to be coming to my home to teach my dog to sit in the kitchen? Or is it a trainer? And it can get a little muddy sometimes. I think even trainers have some not knowing which path to go. And I've heard this comment like, I'm afraid to talk to them. I'm like, just reach out to them. They all talk, right? They just, then, and it's like this sometimes strange, like, I don't know, like there's a wall up between the veterinary behavior community and the training community, but it shouldn't be like that, right? It's we're all working together to help the dogs and cats in our care. And so do you have any insights there as far as you kind of laid out what you do, but do you think, what can we do as a community to help each other, like connect more?
Yeah, I would just say love when people come in with trainers on board. We love when people reach out about cases that they think might be warranting referral, or if people come in with a really good trainer, then we're like, oh, heck yeah, again, this makes our life easier. So yes, I would never want someone to feel like I can't reach out because it's so much better when they are working with someone like that. And it's very uncommon to get referred by someone that we would then look and say, oh, we got to change a lot about what we're doing with this pet from a training perspective. Those styles of training and things we don't get a lot of referrals from, shock collar camp trainers. It's just, that's not the style that ends up on our door typically.
Sure. Yeah. Which is, it kind of works out for you in some ways. Yeah,
because that might be a little more awkward
Yes. Yeah. It's always hard. I'm sure you having it. And same thing for trainers. If their clients seeing a veterinarian that might be giving advice that is not part of their plan, that's a tough side of things to navigate. But If you guys get a chance, go listen to the episode with Dr. Chris Pockle, and we've talked about, how to mend those issues or those relationships as well.
Yeah.
Okay, so in the last 5 or 10 minutes here, I'd love to hear maybe about an advanced case. Now, so we have a lot of dog pros and veterinarians and people that are working behavior cases in the listenership here. So walk us through maybe a case or two, something just top of mind, some advanced case, some unique insight or discovery, or something that went really well for you in your practice.
We had a very recent one that I think from a team perspective was fun, where the pet came in for fear aggression of unfamiliar people, but also one of the big issues was really challenging to see at the vet, and had kind of been either like pulled through a door for rabies injections or put in a squeeze cage. So really like last resort handling techniques. So I've worked with this family for a long time, and we'd gotten so much better on leash reactivity and people coming in the house, but the vet visits were still not going well, and despite medications and things like that. But we finally were able to convince the pet parent to onboard a trainer in their area, because they were not local to Charlotte, and work on injection training, which I think is such a cool area. So we call it the Squish and Boop, which is from Ohio State, where I did my training. But just training a dog to be, cooperative care world, being very willing participant in not sneak attacking, and so being very in on the game of how to do injections. And so still, again, it's expectations. The goal was not, let's get this dog examined and vaccinated wide awake, but it was like, we've got to make injections doable for this pet. So they worked really hard with the trainer, and then the trainer was able to go with, because the primary care was like, heck yeah, whoever wants to help. So the trainer came day of the visit, and we were able to get her a much less stressful sedated exam earlier this week, which is super exciting.
Yes. Such a big hurdle for some of my clients too, is just getting to that vet to get the basics done. The dog can't be handled. Sometimes that, and the game-changing aspect of it when it finally gets done, and seeing like the relief on the person's face, and and if it's done in the most efficient way and most caring way for the dog, the kind of relief the dog gets to, like, that wasn't so bad. I had Tabitha Kucera, who's a LVT and does a lot in the handling side of things, just gave a wonderful webinar on handling cats and dogs that can experience these issues. And it's one of the misconceptions, I think, especially on the trainer side, that I've seen, is we have lots of lovely cooperative care techniques. And when we're doing it on video, it looks perfect at home. So we get these lovely chin rests, the dog's all happy, food's involved. But we have to remember that's not going to look perfect in the veterinary environment, especially if you haven't practiced there. And practicing there as much as you need to have a completely visit that's showing no signs of stress at all is next to near impossible most of the time. So it's just something I like to mention, because we see, again, social media influencing us like the perfect situations all the time, but it doesn't look like that. The goal is decreasing the intensity and frequency of the stress for the dog, and making sure they feel safe as possible, but still getting what we need to get done as caretakers, right?
And I think part of like that case was they put an immense amount of work into it. So this was not like they worked on it for 2 weeks and then it was, we started working on this months ago. So yes, with cooperative care and veterinary handling, if you want to go down this path, it is going to be time intensive typically.
Yeah.
So trying to set expectations for that.
Can you tell us about another case where maybe you've had a high degree of aggression, either high bite level, multiple bite injuries, something unpredictable, sort of a difficult aggression case where you've seen success, and what did you do to make that happen?
So we see just so many aggressive cases. I'm trying to pick one that could be most relevant.
Something that surprised you, maybe, that like I wasn't expecting that to happen, because this dog is like really, you didn't think it was a good prognosis, but it turned out maybe.
I would say one of the more surprising ones, and I hate to keep bringing things back to physical issues, but one of the, I would say, quick fix surprising cases that I've had in recent memory, I saw a golden retriever that was about 2, no obvious gait abnormalities, but I saw her for resource guarding, but kind of abnormal resource guarding. These people weren't trying to take rawhides from the dog. They were trying to pick up pieces of fluff from across a room, but would traverse a room, bite the owner, very severe aggression for triggers that we would consider benign. So that dog came in, but when she was in the appointment, she was just very dull, and she was a golden retriever, just a very dull dog. She just she didn't wag her tail. She just laid in the corner. She wasn't frenetic. She was just very dull. And her gait looked okay, but we had them do videos of going up and down a flight of stairs and, walking up and down a hallway at home where she's in her normal environment, getting up from laying down. And then you could see in that she had intermittent bunny hopping. You could just see she had more of a hard time than she should have. And again, I'm aware there's different feelings about Librela, but we recommended, let's try Librela for a couple months. We, at the same time, did fluoxetine and did a lot of management things for the resource guarding, and she had other aggression things towards the owners. And then long story short, she is strictly on Librela. She is not on any anti-anxiety medications. They sent me a video of her they said, we didn't know she had a personality. Huh. They're not usually that easy of fixes where it's pain only, but that was I was like, oh my gosh, that poor dog, But it was its whole problem was just, it was so painful. And Librela ended up being the ticket for that dog, which was really cool.
It's kind of bittersweet in a way when the pain meds kick in and as you see such profound changes, but at the same time, you're like, the poor dog was suffering from that for so long. And then just trying to express to the world, hey, I don't feel well here. And finally, something's done. That's definitely seen a fair share of cases. And the interesting thing too, I don't know if you had a case like this, is sometimes the context in which the pain events have happened that have been exacerbated by something. So I've had a case shared with me. There's dog had spine issues in the neck area and was, the previous trainer had tried to address resource guarding of the food ball using an e-collar, and it was around the food ball. So guess where the dog started attacking the people? And it wasn't the classic guarding case of I approach your food ball. It's you're approaching with a food ball. So, which doesn't make a lot of sense to people. Like, wait a minute, I have the resource. I'm bringing you something good and then you're attacking me. And it's hard sometimes for people to put their mind around it as well. It sounds like resource guarding. It seems like it's the food, but it's really not. It's the context of I could be in pain when you bring that food ball out.
Yep.
And then once the pain is resolved, the behavior completely changes and dissipates. So it's actually not a resource guarding thing in the general sense. It might start out, but the major exacerbating factor was pain. So. Yeah,
and it's kind of whenever they don't follow patterns that we anticipate, there's this question of like, what are we missing here? Why it's just, when it's a weird presentation, it automatically rings like either something off in the environment or something is off with the dog, and just what piece are we missing? Because it's not a normal presentation.
Yeah. I love those kind of cases. I don't like seeing the dogs in that, but I love problem solving those kind of.
They're very interesting.
Yeah. So in this regard, if you have one takeaway message for everybody as a vet behaviorist, what would it be? Just you're like saying, I wish everybody out there knew this when it comes to helping dogs. What would it be?
I think in general, we would love to see pets as soon as possible if they are starting to notice issues. So I would love if people brought it up to their veterinarians that they had concerns about behavior, and then they could kind of get pointed in the right direction, either from a training perspective or a veterinary behavior perspective. But we tend to select for very last resort scenarios where it can be sad, I guess is the right word, to kind of look at a history and say, man, if we could have seen you 3 years ago, we really could have had a different outcome than what we're dealing with now. So we always wish we can see cases as soon as they're starting to see issues, because you can have such a different outcome, and just helping them get the right resources as soon as possible, as opposed to, potentially doing things that may accidentally, by no fault of the owner, they're trying their best, but, potentially do things that might push us in the other direction for a couple of years, and then we kind of get on board. So
yes, I 100% concur with that thought. I wish people would come to see the professionals much earlier than letting it escalate or spiral out of control, or the emotions, and there's so many other things that can happen if you wait. So Maggie, this has been wonderful. Where can people find you or learn more about you and anything you're up to, and where do you want to send people to if you have anything going on?
Yeah, so I am in Charlotte, North Carolina. So we have Southeast Animal Behavior and Training for anyone in the North Carolina-esque area. And then we also have virtual veterinary behavior medicine. So that's our virtual option for folks that may not have a veterinary behaviorist available to them locally. We have that for anyone in the country. On that service, we do typically monthly race-approved CEs for anyone. The credit for CE is available for RVTs and DVMs, but anyone's able to join those, and we just go over a behavior topic every month. So I think we already did January, but February's will be inappropriate elimination in cats. So those are obviously virtual. And then, that's kind of what we're up to. And then just living a clinical life,
Wonderful. Maggie, thanks so much for coming on the show. I learned so much. I wish I could have you on for the rest of the day, but I wish you well in the future, and I hope to see you again.
Yeah, thank you so much for having me. This was very fun.
What an absolute pleasure it was chatting with Maggie and hearing how she's helping dogs and their people navigate even the most complex behavior cases with empathy, science, and a truly collaborative spirit. Her insights into medication, pain, and the emotional toll on caregivers offer a valuable perspective for anyone working in this field. And if you're ready to go deeper into understanding and helping dogs with aggression, visit aggressivedog.com. Whether you're a professional or a dedicated dog guardian, you'll find everything from the Aggression in Dogs Master Course, which is the most comprehensive program of its kind, to expert-led webinars, informative articles, and the Aggression in Dogs Conference happening from September 26th to the 28th, 2025 in Charlotte, North Carolina, with both in-person and virtual options. And don't forget to check out our Help for Dogs with Aggression bonus episodes, which are solo shows where I walk you through real-world strategies for issues like resource guarding, fear-based aggression, territorial behavior, and more. Just hit subscribe or head to the show notes for more info. Thanks for listening in, and as always, stay well, my friends. Friends.